In this lecture, we will discuss about diabetic retinopathy. So, diabetic retinopathy is a very important public health hazard in these days, and it is a significant cause of vision loss. So that's why everybody should be aware of what diabetic retinopathy is and when should we do screening and what is the treatment. So these are some of the objectives of today's lecture. So to make the lecture interesting, I have put on some imaginary or real world cases of diabetic retinopathy. In case number one, it's about a 45-year-old female with uncontrolled diabetes since last 5 years, and she never had an eye test before, and suddenly she presented with vision loss in the right eye. So that is the common way in which many of patients of diabetes present. So what do you see? This is a fundus photograph in which you can see that there is a hemorrhage in the inferior portion, and this hemorrhage is in front of the retina, that is in the vitreous hemorrhage, in the vitreous cavity. So this is a typical presentation of proliferative diabetic retinopathy. So that's the diagnosis. The diagnosis is vitreous hemorrhage with proliferative diabetic retinopathy. So this patient was treated with pan-retinal photocoagulation of both eyes, and this case underscores the importance of fundus examination in diabetes. As soon as diabetes is diagnosed by a physician, or sometimes it is diagnosed before any surgical procedure, we should always undergo an eye examination. The patient should always undergo an eye examination. The second case, there is a 64-year-old male with uncontrolled diabetes since last 10 years, and he presented with blurring of vision in left eye since 2 months, and there are other comorbidities also, such as hypertension and increased in lipids. So what's the diagnosis? So if you look carefully in this fundus photo, friends, you can see there are multiple hemorrhages in the retina, all the retinal quadrants, and the veins also appear to be dilated. But the main finding is in the macula. The macula is edematous and it is showing exudates in the macula. So the patient is having blurring of vision because of affection of macula. So that is the diagnosis is diabetic maculopathy. So the diagnosis is diabetic maculopathy with clinically significant macular edema, and then the patient was treated with intravitreal injection of Avastin in the left eye. And as the patient had these comorbidities were also important in causation of diabetic maculopathy, so the patient was advised to observe strict control of blood sugar, lipids and blood pressure, and the patient was kept in follow. So these are two illustrative cases or two ways by which diabetic retinopathy presents. So friends, diabetic retinopathy is a silent killer of the vision. It doesn't have any symptoms like pain, redness, irritation, itching in the eye. The patient will complain only of visual disturbances in the later stage. So that underscores the importance of early diagnosis of diabetic retinopathy by periodic eye checkups in diabetic population. So how do we define diabetic retinopathy? So basically, diabetic retinopathy is because of affection of blood vessels of the retina by diabetes. So it is progressive dysfunction of the retinal blood vessels caused by chronic hyperglycemia. That is the definition of diabetic retinopathy. So the number of people with diabetes is projected to rise from 28 crores, means to 285 million, to 439 million in 2030, and it is responsible for 1.8 million out of 37 million cases of blindness throughout the world. And in the industrialized world, where the cataract blindness is reduced to great extent, diabetic retinopathy is leading cause of blindness in people of working age in industrialized countries. In India also, it is catching up fast. So these are the two pictures. On the left side, you can see a fundus photo of healthy retina, in which you can see a beautiful optic disc, from which blood vessels arise, and there is macula in the center. So on the right side, if you see that these blood vessels are slightly tortuous, and in the retina you can see multiple hemorrhages and hard exudates, and in the macula also you can see edema and hard exudates. So this is how diabetic retinopathy looks like. So if somebody shows you fundus photo, you can easily make out what is healthy retina and what is diabetic retinopathy. Diabetic retinopathy doesn't occur in all patients of diabetes. So there are certain risk factors which which make the onset of diabetic retinopathy rapid and which makes the diabetic retinopathy more severe. So what are these risk factors? Duration of diabetes. As the person duration increases, the risk of retinopathy increases. Then poor blood sugar control, that is very very important, especially in Indian settings, and presence of comorbidities like hypertension or hyperlipidemia. And India, there are barriers to care because rural population may not have access to regular fundus examination by ophthalmologist, or the number of retina specialists also may be less. So, and the patients may be non-compliant because of increased cost, because many times the treatment of diabetic retinopathy is very costly. So these are some of the barriers to care, and that will increase the risk factors or the risk of blindness because of diabetic retinopathy. So there was a trial called as the Diabetes Control and Complication Trial, which basically assessed whether control of diabetes reduces the risk and severity of diabetic retinopathy. So what this trial deduced? This trial found out that the intensive control of diabetes reduced the risk of developing diabetic retinopathy by 76% and slowed progression of retinopathy by 54%, and it also reduced the risk of clinical neuropathy and albuminuria. So these are some of the these were the risk factors of diabetic retinopathy. So what is what is the pathology behind diabetic retinopathy? In diabetic retinopathy is a microvasculopathy that causes occlusion of capillaries of retina, and the cell wall of the capillaries gets damaged and the capillaries become leaky. So basically it affects small blood vessels, and the small blood vessels basically become occluded and their architecture becomes leaky, and that causes the findings. So what happens? First thing is that there is microvascular occlusion. Micro means small, vascular means blood vessels. So it causes occlusion of small blood vessels, diabetes. So this is because of thickening of capillary basement membrane, then abnormal proliferation of capillary endothelium, and increased adhesions of platelet under the lumen of the blood vessels, increased blood viscosity, and defective fibrinolysis. So all this will cause microvascular occlusion. And then there is leakage from the blood vessels, and this leakage is because of loss of pericytes. Friends, pericytes are an important component of small blood vessel wall. They form the architecture, or they form the backbone of the small blood vessel wall. So when there is loss of pericytes because of diabetic retinopathy, then the capillaries become leaky. Then there is impairment of endothelial tight junction, and there is weakening of capillary walls and elevated levels of vascular endothelial growth factor. This VEGF is very important in diabetic retinopathy. So this shows, if you can observe that the red blood vessels are basically arteries, and the blue blood vessels are veins, and in between that the arteries will proliferate to form arterioles, and the venules basically drain into the veins, and in between this there is capillary bed. So basically the small blood vessels of arterioles and venules and capillaries are affected, and these are the changes which I have discussed before in the previous slide are shown here, that there is thickening of basement membrane, then there is damage to the endothelial cell, and there are changes in RBCs and platelets that make them more adhesible or more prone for adhesion to the vessel wall, and there is loss of pericyte. That is very very important. So what happens, friends? Then because of the occlusion of the capillaries and arterioles, there is ischemia of retina. The retina becomes ischemic and hypoxic. The oxygen supply to the retina decreases, and this leads to secretion of VEGF, that is vascular endothelial growth factor, by the retinal capillaries, and this factor causes proliferation of new blood vessels. It causes formation of new blood vessels which are not desirable. So that leads to proliferative retinopathy. New blood vessels are also formed in iris, leading to iris neovascularization or rubeosis iritis. And because the capillary bed is occluded, abnormal shunts or channels are formed between arterioles and venules. These are called as avation. Then what are the consequences of leakage? So what happens because of leakage? See, in this picture you can see that the capillary vessel walls are abnormal, and there is outpouching of the capillary vessel wall that is causing microaneurysm, and the capillaries become leaky, so the lipid substance from the blood leaks into the retinal tissue, leading to formation of hard exudates. So these are the if you anatomically see that the lesions are located in various parts of the retina. So we'll discuss about the lesions later, but you can see that flame-shaped hemorrhages are located in the superficial or inner layer of retina, whereas dot and blot hemorrhages and these hard exudates are located in the slightly in the middle layers of retina. They are located basically in outer nucleus and inner outer nuclear and inner plexiform layer. So what are the symptoms of diabetic retinopathy? The first and foremost thing is that diabetic retinopathy is asymptomatic in early stages of the disease. As the disease progresses, the patient may complain of blurring of vision, then floaters. Floaters means dark or small dark moving objects in front of the eye, and these floaters are because of hemorrhages in the vitreous, and the vision may be fluctuating because of the swelling of the lens. Sometimes in uncontrolled diabetes there is swelling of the lens and the refractive error changes, so there is a fluctuation of vision. Then distorted vision, once the macula is affected, then the vision is distorted. The patient may see a small object, small size of object, or big size. The objects are looking bigger than normal or bigger than actual, or the objects may be distorted. Then there is scotoma, there may be dark areas in the vision. For example, if there is hemorrhage in the inferior quadrant, then the patient will say that there is the patient will have superior scotoma. Patient cannot see. Patient will see a black curtain or black something black that is obstructing the superior field. So these are called as scotomas. Then there may be poor night vision, impaired color vision. Color vision is a function of macula. So if macula is affected, then the color vision may be impaired. And lastly, there is partial and total loss of vision. So most of the symptoms are related with vision. There are no external symptoms like pain, itching, redness of the eye, or discharge from the eye. So what are the symptoms? The symptoms are blurring of vision, which may be gradual or which may be sudden, then floaters, then the fluctuating vision, then there is distortion of vision, that is called as metamorphopsia, and there may be scotomas, and then lastly the patient will have partial or total loss of vision. So as we have as you must have known from the previous slide, that eye examination is very important, because in the initial stages diabetic retinopathy is asymptomatic and we can treat it easily. So that's why it is very important that the patient should have regular eye examination. So what is the recommended time of examination? In type 1 diabetes, usually type 1 diabetes starts in the young age. So the recommended time of first examination is 3 to 5 years after diagnosis, and follow-up is yearly. And type 2 diabetes, the patient should have the fundus, dilated fundus examination at the time of diagnosis, and follow-up should be yearly. So this is about severity of diabetic retinopathy. So basically, if you want to classify diabetic retinopathy, you can I can tell you very simple way to classify it. Either it can affect the background retina or peripheral retina, leading to background diabetic retinopathy, and or it can affect the macula, leading to diabetic maculopathy. And these frequently coexist. Maculopathy and background retinopathy are frequently present in at one time in single patient. So depending upon the stages or the severity, background diabetic retinopathy can be classified into proliferative and non-proliferative. Non-proliferative means there is no proliferation of new blood vessels, and proliferative means proliferation of new blood vessels. So proliferative and non-proliferative. And maculopathy again can be classified in various types, but the most important thing about diabetic maculopathy is there is one term called as clinically significant macular edema. So that is very, very important. So if you want to classify diabetic retinopathy, it is either proliferative or non-proliferative and diabetic maculopathy. So these are the three types of diabetic retinopathy. So this picture, there is no, you can see no retinopathy. Retina is absolutely clear. So what happens in mild non-proliferative diabetic retinopathy? Mild means mild in the initial stages. Non-proliferative means there are no proliferation of new blood vessels. So what happens is that we can see only microaneurysms. Okay, so here you can see microaneurysms. Microaneurysms are nothing but outpouching of the vessel wall. We have seen in the previous slides that the capillary parasites are damaged and the architecture of small blood vessels gets affected. So there may be outpouching of the vessel wall leading to microaneurysms, and that is the beginning of diabetic retinopathy. And if you can see, how do you detect microaneurysms on fundus examination? You can see a very small tiny comma shaped red dots in the retina. So this may be confused with dot and blot hemorrhages. Okay, but that is the finding of, that is how that is how the microaneurysm look like. So how to confirm it? We can confirm it by doing fluorescein angiography, in which the blood vessel wall will be lineated. In moderate NPDR, it is more than just microaneurysms, but less than severe NPDR. So what does that mean? थोड़ा सा disease आगे बढ़ गया है. Apart from microaneurysms, there are few other changes. So what are these other changes that we'll see? Yeah. So you can see that there are yellow discrete patches, opacities in the retina. So these are nothing but hard exudates. And you can also see that there are hemorrhages in the retina. So these hemorrhages are of two types. Flame-shaped hemorrhages are superficial hemorrhages, and they are characteristically present in the nerve fiber layer, and they take the shape of the nerve fiber. So that's why they are flame-shaped. And the deep hemorrhages are present in the deeper layers of retina, and they are usually dot or blot type. So moderate proliferative diabetic retinopathy, what is the presentation? You can see microaneurysms, you can see hard exudates, and you can see flame-shaped hemorrhages or dot and blot hemorrhages. Yes. So you can see here that there are hard exudates in the macula, and there is microaneurysm inferiorly. See this black patch, blackish or bluish patch inferiorly is not related with the diabetic retinopathy. Probably this is a nevus in the retina. So what happens in severe NPDR means we are progressing. The natural history of diabetic retinopathy is progressing. Now what happens? There is one rule called as 4-2-1. So that rule has to be followed for the diagnosis of severe NPDR. So for any one of the following: more than 20 hemorrhages in retina in each of 4 quadrants. Retina is divided into 4 quadrants: superior, inferior, temporal and nasal. So more than 20 retinal hemorrhages in each of the quadrant. Then venous bleeding in 2 or more quadrants. Venous bleeding means dilatation of big veins, and it is considered to be more severe feature. So that's why if venous bleeding is present in 2 or more quadrants, we can deem the patient is having severe NPDR. And prominent intraretinal microvascular anomalies, so IRMAs. So IRMAs are nothing but the shunt between arterioles and venules, which we have seen in the slide of pathology. So prominent IRMAs in 1 or more quadrants is considered to be severe NPDR, and no signs of proliferative retinopathy. So you can see that there is venous bleeding in this slide, so we can deem it as severe NPDR. So again, this picture shows how does NPDR look like. You can see multiple hemorrhages, you can see hard exudates in the retina, and if you count, probably there are more than 20 hemorrhages in each of the quadrants, so it is severe NPDR. So if you do fluorescein angiography of NPDR, fluorescein angiography means what do? We inject fluorescein dye in the patient's vein, and then we serially take the fundus photographs, X-rays, fundus photographs of the eye, like what we do in angiography. We take X-ray. So instead of X-ray, we take fundus photographs, and you can see that this dye appears in the retinal blood vessels, and we can see how the dye progresses, whether it goes only in the blood vessels or it leaks into the retina. And you can see various abnormalities of blood vessel wall also with the fluorescein angiography. So you see this picture in which you can see multiple spots are there just at the end of the blood vessels. So these are nothing but the hard exudates, and you can also see leakage from the vessel wall. And you can see, if you observe carefully, sometimes you can see erymas also in this fundus photograph. So this is fluorescein angiography of non-proliferative diabetic retinopathy. Normally हमको ये सब लीकेज वगैरह नहीं दिखेगा. What we see is only blood vessels in retina in fluorescein angiography. So if you do, there is one more test that is called as ocular coherence tomography, or it is OCT. Basically OCT tells us about anatomy of the retina. So in the macula you can see that there is hemorrhage, there is swelling in the macula, so there is macular edema. So we have seen that the 3 stages of non-proliferative diabetic retinopathy: mild, moderate and severe. उसके बाद क्या होगा? If we don't treat it, the patient progresses into proliferative diabetic retinopathy. So what is the hallmark of proliferative diabetic retinopathy? That there is presence of new blood vessels in the retina. So the ischemia, the extent of ischemia or hypoxia becomes so great that vascular endothelial growth factor is produced in abundant quantities, and it leads to formation of new blood vessels, and this is called as neovascularization. So one may wonder whether this is beneficial or harmful to the retina, but it is harmful to the retina because these new blood vessels are not like normal blood vessels. They are not very robust blood vessels. They are very fragile blood vessels, and they grow inside the vitreous cavity also, unlike the normal blood vessels which are confined to the retina, and that's why they are leaky. So they rupture and they cause hemorrhage into the vitreous, that is called as vitreous hemorrhage. Then they also cause detachment of the retina. They pull on the retina, they cause fibrosis in the vitreous, and this fibrosis will pull the retina, causing retinal detachment, and the patient loses the vision. So this is one of the way in which the patient loses vision in diabetes. So that's why proliferative diabetic retinopathy is considered to be a serious or grave condition which requires immediate treatment. So what are the characteristics of proliferative diabetic retinopathy? There is neovascularization, and there is hemorrhage in the vitreous, or before the vitreous, or before the retina, so in front of the retina. So that is called a pre-retinal hemorrhage. Okay. So basically the blood vessels may grow on the surface of disc or in the periphery of retina. So if they grow on the surface of the disc, as shown in the arrow here, so this is called as NVD, or neovascularization on the disc. So normally, how do you distinguish between normal blood vessels on the disc and this neovascularization? So these new blood vessels will be always raised from the surface. They will be seen as going into the vitreous, whereas the normal blood vessels are on flat. They are not raised above the surface. So that is how we can distinguish between NVD and normal retinal blood vessels. And NVE means neovascularization elsewhere. So in that also you can see tuft of blood vessels, like fan-shaped blood vessels which are growing from the retina into the vitreous cavity. So they are oriented perpendicularly, and normal blood vessels are usually oriented horizontally. So NVD and NVE, and NVD is more considered to be more severe stage than NVE. So high risk PDR means already PDR is high risk, because PDR the patient may lose vision anytime. So but If one of the following three of the following four factors are present, then it is called as high risk PDR, and it is at high risk or at risk of causing serious vision loss. So presence of vitreous or pre-retinal hemorrhages, so presence of new vessels, then location of new vessels near optic disc, and moderate to severe extent of new vessels, this makes the PDR high risk PDR. So you can see in this slide, friends, that very classically you can see the presence of new blood vessels on the disc, so that is NVD. You can see superiorly आप देखो, so you can see that the blood vessels are growing from the superior part of the disc and they are projecting like a fan. Okay, so that is PDR. Here there is NVE in the superior quadrant, and this has ruptured and led to a big pre-retinal hemorrhage in the superior quadrant. This red color is hemorrhage. So if you do fluorescein angiography, what is the characteristic finding of proliferative diabetic retinopathy? You can see new blood vessels, and the hallmark of new blood vessels is that they leak very very profusely. उनका लीकेज बहुत प्रोफ्यूज होता है, and that is present in all phases of fluorescein angiography. There are various phases of fluorescein angiography. So early and profuse leakage is the hallmark of PDR or proliferative diabetic retinopathy. So here you can see that the inferiorly the blood vessels have leaked and they had caused inferior vitreous hemorrhage. Vitreous hemorrhage can also be diagnosed by ultrasound, in which you can see shadows into the vitreous cavity. And then tractional retinal detachment. This I already told you that when the vitreous when there is hemorrhage in the vitreous, then it causes fibrosis, and this fibrosis will pull on the retina. It will exert traction on the retina, causing tractional retinal detachment. The retina gets separated from the pigment epithelial layer. So this is called as TRD or tractional retinal detachment. It also can cause membrane on the retina because of the fibrosis. So this membrane will be called as epiretinal membrane. So this is again you can see that you can see that there is a detachment of the retina. You can see classically that there are membranes in the vitreous cavity and they are pulling on the retina. Rubeosis is nothing but presence of new blood vessels on the iris. So in the severe stages of diabetic retinopathy, because of this VEGF, there is proliferation of new blood vessels on the iris also, and these new blood vessels can cause glaucoma, and this glaucoma is called as neovascular glaucoma. So that is another complication of diabetic retinopathy. So what are the mechanisms of vision loss? So let us summarize or discuss the mechanism of vision loss. So ischemia of retina because of diabetes can cause vision loss in itself, especially in the macula. If the macular area is ischemic, it can cause vision loss. Then edema in the macular area can cause vision loss because of the edema, the nutrition of photoreceptors is affected, and if the edema persists for say more than 3 months, then the photoreceptors are permanently damaged, leading to macular leading to vision loss. Then vitreous hemorrhage will also cause vision loss. Then epiretinal membrane formation, the light rays will not reach the proper retinal layer because of this membrane over the on the retina, leading to vision loss and detachment of the retina and neovascular glaucoma. So these are some of the causes or mechanisms by which the patient loses vision loss because of diabetic retinopathy. So friends, I hope you have understood the basics of diabetic retinopathy in this lecture. In the subsequent lecture, we'll discuss about how to treat, how to diagnose, and how to treat the diabetic retinopathy. If you have any doubts, please feel free to ask me anytime. Thank you so much.